Welcome back to the show. If you've been anywhere on the internet lately, you've heard the buzzwords: peptides, GLP-1s, microdosing, fat loss stacks, recovery injections, hormone optimization, maybe even someone in your DMs selling something that sounds like it came out of a sci-fi movie. And if you're a woman in your 30s, 40s, 50s, or 60s trying to make sense of your body, weight changes, energy shifts, cravings, sleep issues, brain fog, perimenopause, inflammation, this whole space can feel equal parts promising and chaotic. So today's episode is designed to do one thing: bring clarity. Not hype, not fair, just a practical, physician-led conversation about what's real, what's overblown, what's actually safe, and what might apply to you. Our guest is Dr. Greg Jones, a naturopathic physician and the founder of and medical director of Innovative Wellness Center in Phoenix, Arizona. He's a leading expert in peptide medicine and teaches internationally on peptide therapy, bioidentical hormone replacement, regenerative orthopedic injections, and IV nutritional therapy. He also serves on the board of directors for the American Association of Naturopathic Medicine, and he hosts the Dr. Jones Optimization Academic podcast. He was actually on my podcast in episode 15 in July of 2024, so you could check that podcast out as well, where we discussed cagrilintide, which was a new GLP-1 at the time, and also microdosing GLP-1. In this conversation, we're going to break peptides into clear buckets because a lot of people use that word to mean totally different things. We'll talk about metabolic options, including GLP-1 and what's coming next, like the multi-agonists you may have heard about, retatrutide. We'll get into the real-world troubleshooting women actually need, so nausea, reflux, constipation, fatigue, plateaus. What helps first, and what should prompt you to stop and call your clinician if you develop these symptoms. And then we'll zoom out into questions that matter for long-term health: how to protect lean muscle, bone density, mood, libido, and metabolic rate, especially for women navigating perimenopause and menopause. We'll also cover physician prescribing peptides people ask about all the time, like CJC with ipamorelin, tesmorelin, and we're going to talk about safety first lenses, goals, what's realistic, who should avoid peptides, and what monitoring should be non-negotiable if you're considering peptide therapy. And because sourcing is a major issue right now, we'll close with a plain English breakdown of 503B compounding pharmacies, plus a red flag checklist you can use immediately, so you're not gambling with your health in the name of faster results. If you've ever thought, I just want someone credible to explain this without talking down to me, this episode is for you. Let's get into it with Dr. Greg Jones. So today we're going to talk to Dr. Greg Jones. I actually had him on the podcast, you guys, episode 15. So long ago. It was July of 2024. I don't know if you remember, but it was like right after we met at the Peptide conference, the SEEDS conference in June, I think, of 2024. So I brought you on episode 15 and we talked about cagrilintide. That was when it was like brand new. It's a peptide that you can use in conjunction with GLP-1s for weight loss. And we talked a lot about microdosing. So if you guys did not listen to that initial episode, go back and find episode 15. But I'm so happy that you decided to come back on today because I want to talk to you about a lot of things, right? So one of them is weight loss, right? So weight loss, hormones, gut health, thyroid, peptides, it's kind of everywhere, right? And online is so chaotic. Women are so confused. They're like, what do I do? What is right? What is not right? So I want you to come and help us make sense of it because you do a lot of peptide therapy and you're always putting a lot of great stuff out about peptides. I share it and repost a lot of it. So before we get into specific compounds though, how should women think about root cause versus tools, right? So like hormones, thyroid, gut, lifestyle, medications, peptides, all of that. It's not just like, we shouldn't just be thinking about like what I can take, right? So if you're listening to this, people shouldn't just be like, oh, I'm just going to take a peptide and be better. Explain to women why you have to be doing other things in order for peptides to work. Or do you? Can you just take a magic shot and everything's better?
Yeah, and I think that the important thing about it, and I want you guys to think about this like a pyramid, right? And at the bottom of that pyramid, the foundation of your pyramid, foundation of your house, if not into Egypt, how like that, is the foundation is your lifestyle, right? Your diet, are you working out? Are you drinking enough water? And whenever I think about these lifestyle factors, I'm like, all right, I always start with what you eat, right? Because trash in, trash out. trash in, trash product, right? And so if you're eating a ton of sugar, you're drinking a bunch of alcohol, you're eating processed foods, ultra processed foods, you're literally setting up roadblocks in your path to health, and that's unfortunate, right? And I'm not saying, and I get it, especially if if you know better, you do better, right? And so it's always good to think about. And we talked about this last time. I do remember we said, hey, at the very least, there's 6 or 7 things to cut out, and we talked about sugar, gluten, dairy, processed food, alcohol, artificial things, and we put that all in the mix because that's a good starting foundation, right? And at the very least, look, if you got a pantry full of this stuff, you may have to slowly break things down, but that's where you start. And then you want to make sure you drink enough water. You'd be surprised how many people, I always like give people that side eye, like, I don't like water. I'm like, who doesn't like water? And they're like, I don't like drinking water. I got to put something in it. I'm like, hey, man, go for it. And no, coffee is not considered hydrating. It's actually negative hydration, right? And then you want to make sure, and here's the deal. You have to find a way to get better sleep because at the end of the day, like we're going to talk about these peptides and we're going to talk about these hormones and all these cool things. To me, there are 2 interventions for longevity that are non-negotiable: sleep and working out. Because if you don't work out and if you don't sleep, you can set money on fire all day. I don't want your money if you ain't gonna sleep and not work out. I kind of don't. Because at the end of the day, it's like you're not setting yourself up for success. I'm not gonna kick you out as a patient. I'm like, look, what I mean by that, I don't want you spending money on these things if you're not foundationally ready. There you go. That's a big one, right?
So what I'm hearing you say is no, there's not a magic drug, right?
No, you
There
have to do
are
all that. You
foundations.
have to do you got to do the foundation. You have to. And if not, because if you're just not going to get the best benefit from it. And then what's going to happen is, and you probably see this, Dr. Smith, is that the person doesn't set their foundation. You say, here's the protocol to put you on. They come back 2 months later and it's like, ain't none of this shit working. And you're like, what is it? Then you realize, oh no, I haven't started working out. I have not made the dietary changes. I have not cut this out or cut back on this. So we want to make sure you're doing that. And the other thing I kind of add to the mix when it comes to that foundation is the human detox. As in, if you have like stressful, drama-filled people in your life, you may have to kind of step back from that a little bit too because it affects your stress and your cortisol. And that can affect your life as well. So at the end of the day, there's no magic bullet when it comes to it, right? So, and I'll say this before we move on, is like, you got to make sure that if you're taking something, at the end of the day, there's many things you want to look at. It's just like you said, not just taking hormones. It's like, okay, what are you actually deficient, suboptimal in? What's your body not making? What's it not producing? And there's where you start. It's like, not going to give you vitamin D. Like if you run, it's rare, but if I run your your labs, and your thyroid is 3.9, 4.1 naturally, I don't really see the need to give you something because it seems like you're doing great, right? So you want to make sure you're looking at what's suboptimal and what is deficient.
When you say thyroid, do you mean free T3?
Free T3, yes.
Okay.
Yes, exactly.
He does not.
No, gosh, no.
Okay.
It's so funny. Whenever I think thyroid, I go straight to free T3. If I ever say
Yeah.
thyroid, I'm talking free T3.
Okay. So what I'm hearing you say is that you do need to be doing foundational things before you start throwing peptides into the mix, or it's like catching your money on fire. Now, for listeners listening, though, I want to say he's not saying you have to be perfect. And peptides are tools that help us be better. But to your point, if you are not sleeping, you're eating nothing but garbage, and you're never exercising, it's kind of pointless to think about peptides as adjunctive therapy when you're not even doing the basics. So that's one thing that I wanted people to realize from the very beginning, because I don't want you spending $500 or $1,000 a month on something that might not work. Now, I have a lot of people who spend that kind of money on peptides, but they're doing the basics and we're getting a really long way. So I just wanted to ask you that. And it sounds like you agree that there are some basic things that need to be done other than just injecting yourself. And this is why, and we're going to talk about this towards the end, or we can just talk about it now. But this is why I think a lot of times people also need to be careful with who they're working with when it comes to peptides. If somebody is just writing you peptide prescriptions and you're never seeing a provider and they have no idea what you're doing and they have no idea what your labs look like, and they're just giving you a random, like I had a lady yesterday who said, I got a GLP-1 from an online site. They sent it to me 3 months at a time. They told me exactly how to titrate it. And that was it. And I said, did you see a doctor? And she said, nope. And I said, did you get labs? And she said, nope. And I said, okay, tell me the titration. And it was literally like every week they were doubling it until they got to the max. And I was like, that seems like a really bad idea for multiple reasons, right? So like, I feel like that's important too. And we'll get there. Or you can just give your opinion about that now as far as like if you are going to consider peptide therapy? Should we just randomly be finding someone online? Should we be working with a doctor? Are there people that should take peptides versus not? Does lab work need to be done? What are your thoughts on that?
Yeah, and the thing is, there's no peptide degree, right? So you're not going to get a bachelor's or a master's or a PhD in peptides, not therapeutic peptides. Obviously, if you're doing a biochemistry or chemist, yes, you do. Totally different. And so that being said, are you really going to say, like, if someone called, like, hey, Dr. Smith, is like, where'd you do your peptide training? And no one's asking you that question, right? Well, at least I've had people ask. It's like it's funny, but okay, sure, I'll lay out my bona fides for you. But the reality is like you want to make sure that that practitioner does have some experience with that. And one of the ways is like, you do your homework. It's like, let me go to your website. Let me see, are you putting any content out there? Not saying that's the end all be all, but you want to make sure this person knows what they're talking about for sure. And then there's like certain red flags you kind of look for, especially you kind of hit it. It's like, look, if I'm starting you on peptides that affect hormonal pathways, a GLP-1, a growth hormone peptide, maybe potentially some of the thymosins, depending on the condition that's going on, an IGF-1, things like that. And you don't look at where your hormone levels are, even a Panaylon, because it does affect melatonin. It's like you want to be like, you got to have some type of baseline, right? And it's too easy to say, here's a peptide, but what if that person has a IGF-1 and you're an endocrinologist? I mean, I'm probably speaking your language. If that person comes in with an IGF-1 of 600 and they're not on a peptide, and I just say, hey, let me put you on without looking at labs, not knowing that, and I put you on like a growth hormone releasing peptide or an IGF-1, what am I really doing to you? What's really the issue? And it's like there's some caution to it. And I'll even put the GLP-1s in there. It's like, and I was really hardcore on this in the beginning, but like I still check it very, relatively frequent on patients. I'm checking your amylase and lipase, especially the lipase, because it's really the only way I'm going to know if you're starting to push towards pancreatitis is if I'm knowing what your pancreatic enzymes are doing. And if you start a GLP-1, let's just say your baseline lipase is 15, and then you run those labs again and there's 600, 700, that's a problem when it comes to lipase, right? Because it's more specific for pancreatitis and amylase. And so things like that, you want to make sure we're being smart with, right? Because you have to make sure you're protecting the patient before these things are helpful and they've been life-changing for so many people, but they're not for everyone. And the lab work is going to be a big way to help make that decision.
Lab work and symptoms for sure. So you mentioned red flags. What is your top red flag checklist for a peptide clinic or online seller? So like if somebody was thinking about working with somebody online to get a peptide because maybe it's cheaper, what would be a red flag that you say people should look for?
Yep, I say we hit the big one. It's just like, hey, I'm going to start you on this entire 5 or 6 peptide protocol without doing lab work. That's a big one. Another one for me, if there's no check-ins, if it's like, hey, here's 3 months of this, I'll see you in 3 months, and we don't have a discussion to know, like you said, if you're having side effects, how are you feeling subjectively? If you're just giving me these peptides and there's no, how are you doing on it? Are you having any side effects, injection site reactions? If you're on a GLP-1, are you getting nausea, vomiting, reflux, headaches, things like that? I want to make sure we're checking all these things, right? Those are like 2 really, really big ones. And then the other thing is like, if the peptide, basically comes in and we'll talk more about this, is like, especially if you're going to an actual clinic and it comes in a vial that says not for human use, concerning, I would hope that no clinics are doing that, but also we've heard some news stories about things happening out there. That is a really serious thing, right? Especially if it says not for human use. That is, if that's coming from a clinic, that's a ginormous kind of red flag for me.
Okay. Those seem like normal red flags to me as well. So,
do you have any other ones? I don't know if there's similar.
yeah, I mean, I think that that's a really good point. Like I talked to a lady yesterday who wanted to start some GLP-1 medication. She had done it in the past. And then I said, okay, well, I want you to come back in 8 weeks because I want to do another in-body scan. I want to see how you're doing. And she seemed very put off by that and was like, well, I'm really busy. And I'm like, okay, well, if I give you this medicine and you leave for 6 months and then you come back in 6 months and you've lost 20 pounds, but 15 of it is muscle, we're going to have a really big problem. And that's going to be not only your problem, but my problem as your treating provider, because then you're going to have insulin issues, you're going to have hormone issues, And so I just think that sometimes people think that it should just be this really easy, like, oh, I'm going to take this shot because everyone does it. But it is really important to monitor that. I like to see my patients every 4 weeks, and they don't even necessarily have to see me. I want them to come to my clinic. I want them to get on my in-body scan so that my nurses can see What does their muscle mass look like? The patient can see that, and if they're not having any bad side effects and their muscle mass is not dropped, but we're losing weight appropriately, great. I want to personally see them every 2 months to 3 months at max, but I don't think that we should just be giving somebody a script and never seeing them again, because we as humans, as we lose weight too, sometimes we don't even realize, if you see yourself every day, sometimes you don't realize how much weight you're losing, but it's almost impossible to know whether you're losing muscle or fat until it's kind of too late, right? So, and also the lab thing is huge for me too. I don't check as much lipase levels. I feel like with lipase, a lot of times you'll get symptoms, not saying that you shouldn't. I do check labs. I do check IGF-1, things like that. But I agree, like you need a provider that's doing labs and then making sure that, other than the fact that you have a heartbeat and can pay them, everything's going okay, in my opinion, right?
That's true. It's true.
Yeah. So I love all of that. And we can kind of circle back to some of this too. But I also want to start with the GLP-1s because they're so hot right now, right? Everyone's talking about GLP-1s. Everyone's talking about this. And I think that you can use them appropriately and correctly, but I think that you can also use them inappropriately and incorrectly, and you can hurt people. And so what I wanted to start with is when people say peptides, I feel like there are two really big buckets. You tell me if you agree. There are the prescription incretin medication like GLP-1s, right? So the semaglutide, the tirzepatide, the retatrutide. And then there's this other bucket of just randomly clinically prescribed peptides for everything else, right? Like CJC, ipamorelin, tesamorelin, BPC, things like that. And so I think those are very different peptides. And I think that in my mind, people need to realize that the GLP-1s, there's a lot of data, there's a lot of benefits. It's for, specific use. And then there are all these other peptides that are wonderful and they do different things. And we can talk about that, but they're in my mind, very different too. And so you really, really need to be working with a provider who knows what's going on with the GLP-1 medications. But what is your decision framework as a prescribing physician? Right? Who's a candidate, who's not a candidate, and what monitoring do you require?
So I want to circle back to that first point, and I do put peptides in two buckets, very similar to what you mentioned, but my buckets are, in general, is this peptide and I'm going to use this word because I know people use it different, is it like a bioregulator? And then I know there's a category of peptides considered bioregulators and all this stuff here, but in general, when I put that bucket, is this peptide binding to a receptor and causing the body to do something? As in, when you take a GLP-1 peptide, an example, that GLP-1 is binding to receptors and telling the body to do certain things. And we'll get into that maybe a little bit about reducing appetite, slowing gastric emptying, reducing production of inflammatory cytokines. It's telling the body to do something. So it's working indirectly, right? And that's your growth hormone peptides, your GLP-1s, things of that nature. And then you have peptides that the body is going to use directly. There's no direct receptor for it. There's no KPV receptor. There's no BPC 157 receptor, right? The body is going to use it very directly, right? And that's a different category of peptides. And those peptides honestly tend to be a little bit safer, right? Because you're not worried about affecting any type of feedback loop, suppressing anything, anything that can overproduce or underproduce something, those are a little bit, you want to be a little bit more mindful of those. So in many ways, that's kind of the big two categories. And sometimes those peptides that do not have a receptor that they're interacting with, sometimes I feel like safer doing those without labs because it's there's no lab I can test you for BPC unless I'm looking at your inflammatory markers, your CRP, sed rate, things like that. But it's not like I can measure BPC levels, right? I can't measure KPV, but I can look at the outcomes, which are your inflammatory markers. So it's good to get a baseline. But if someone comes in, I sprained my ankle, especially if it's an existing patient, I sprained my ankle, this shit hurts, what you got for me? I'll probably say, hey man, let's do some BPC. I'm not gonna say, why don't you wait a week? Let's run some labs. Why don't you come back a week later? You just hobble along until I see your CRP. I'm not doing that, right? We'll probably start something sooner. So I think there's there's a breakdown there, and I want to make sure that people know which things are safer to start kind of on a day one thing versus you might want to see what the baseline is. Hope that kind of helps that.
No, I think that's a really good way to look at it. Yes, there are peptides that change feedback loops in your body and hormonal pathways, and then there are peptides that are a lot safer. And I would agree with that. I have people who come in all the time, just had surgery or about to have surgery or sprained their knee. And BPC 157, I feel is a very safe peptide. I even think TB 500 is pretty safe in general. Thymosin alpha, pretty safe. Caveat there is like if you have a really bad autoimmune condition that's flaring, sometimes you can have issues with that. But I agree. There are peptides where it's like any of the growth hormones secreting or, peptides, and then the GLP-1s, you got to be a little bit safer with. So there are two buckets of peptides, but then in general, the GLP-1s are the big ones right now. And we're hearing about this like next generation of medications right now, right? So like I'm hearing it, I'm seeing it, I'm sure you are too. When we last had our conversation, tirzepatide was like the big new guy on the market, pretty much had just started, and then cagrilintide, but now we have retatrutide, right? And so what is the promise with retatrutide compared to other GLP-1s? Like, what is so great about it? What is this, claim to fame with muscle? Do you feel like there's anything still unknown about retatrutide that is scary? Is there a difference with the food craving noise with retatrutide? Because some people swear that they still have the food cravings or that they're even more hungry, but then there's supposedly better muscle retention, right? So talk to me about retatrutide versus tirzepatide. Like, what have you seen? What do you know?
So yeah, I mean, last time we spoke, it was Cagri was a big deal and tirzepatide, and now the next one on the horizon is the GLP-3, which is the retatrutide or retatrutide, depending on where you are located in the country, and it's a triple agonist, and so it is a combination of a GLP-1, like like a semaglutide, a GIP, which is your tirzepatide, and a glucagon agonist, which is the newer piece of it. And what the theory is that the glucagon, when you activate the glucagon receptor, you're getting an increase in energy expenditure. So the body your thermogenic rate is increasing, the body is burning more calories kind of at rest. And some of the earlier studies, when you see it, it's like they had people at the same diet, the same food intake, and you saw that even, at rest, their energy expenditure was increasing at the same amount of food intake as well. And so the theory with that is that, okay, it's going to help with increasing weight loss, also helping to retain muscle a little bit better than some of the GLP-1s and the GLP-1 and GIP, semaglutide, tirzepatide, which is great. And so, and again, when you look at the kind of longitudinal studies on it, they're seeing an overall weight loss, especially when the doses get higher. And that's great. But you did mention one thing, some of the things in the trials that people have noted, and if we were able to get it from pharmacies for a little while, now that's kind of a tricky area. But even before the pharmacies lost it, one of the things that was being noted was that, hey, I'm losing weight, I feel good on this, but the food noise is higher. And so the appetite suppression wasn't as great. And that's something that needs to be accounted for when this peptide becomes more mainstream. Just like, hey, you know what, if you like these benefits of it and appetite's a issue, you might do better on, a GLP-1 or a GLP-2, we'll call it GLP-2 or tirzepatide kind of thing. Or if the appetite suppression is an issue and you want to stay on it, you may have to look at other compounds like a tesofensine or something like that, right, to manage the appetite. So I think there are some other nuances to be known with it. And we were talking a little bit before we started about the Triumph-4 trial is showing this dysesthesia side effect, which is kind of like almost like a neuropathy, tingling, it's like almost like a burning, tingling sensation, like crawling on the skin. And they showed that that was present when people, I think it was 8%, so maybe close to 1 out of 10 at the 9 milligram dose. And it was up to 20%, 20.9% for people at the max dose of 12 milligrams. So that is something that is to be mindful of too when people start getting into this and doing higher doses of it.
Yeah, but I've never given anyone that high of a dose. Like that's a
Yeah, that's
massive.
aggressive. That's aggressive, but, be mindful.
But the interesting thing that I think with this study so far is that it is the only study where women have actually lost more weight than men, right, in a clinical trial. And I think some of it, just thinking from a physiologic standpoint, from an endocrinologist standpoint, from a woman talking to women all day, is because it indirectly affects cortisol and insulin production in our body. And women, we internalize and treat things differently than men. And so we have a lot of high cortisol levels, which inadvertently increases our insulin and does make us stressed. And so I think it's interesting that this drug, women are actually losing more weight than men. And a lot of times it's the very stressed, like what I see in my clinical practice, women who have high cortisol levels. Now, that being said, this medication also has a lot of, emphasis on muscle mass and maintaining muscle mass. It's more of an anabolic type medication. And so I think with this medication, it's also important to talk about some of the fat loss non-negotiables to protect lean muscle and bone health and energy, libido, mood, etc., right? So Who do you think is most at risk in taking this type of peptide for losing muscle mass and bone loss and things like that? Is it the perimenopausal woman? Is it somebody with low protein intake? Is it somebody who's not lifting weights enough? Is it somebody with restrictive dieting? Is it all of the above? Like, what is your thought on that?
Well, it's definitely in this multiple choice test. It's definitely in all the above. I will go to my grave with all the above. This test is easy. All the above, man. I like these kind of tests. It's not like the board question when it's like, is it A and D? Is it B or C? And you're just like, dude, I don't know. I'm gonna pick this because I got 800 questions to answer. So it's very much the all the above kind of thing, right? Because if you are, let's start with the big one, especially with females. If you're postmenopausal, perimenopausal, and your hormones are dysregulated, suboptimal, especially postmenopausal, at that point, you're not even making any hormones, right? And testosterone, so your anabolic ones, right? Your testosterone, your DHEA, the big two, your growth hormone. But also, I'll put melatonin in the anabolic bucket if you're not sleeping. And you mentioned women and cortisol, because what does cortisol do? Suppresses melatonin. So if you're going to bed stressed out, you're not getting your natural melatonin. There goes your sleep, there goes your deep sleep, and that just cascades into difficulty with protein synthesis and building muscle. So hormone optimization is huge. And perimenopause is quite the, be real with you, man. I don't know how I got into treating perimenopause. If I do it all over again, I'll be like, I do everything but that. But of course, it's too late. The train has left the station, and, that's a difficult one, but also we tend to see some of the hormone dysregulation, especially with testosterone in perimenopause as well. So we'll start there. The second big one you hit is not doing resistance training and not strength training. You need to give the body the signal it needs to, like, hey, I need you to build muscle. You mentioned not the macronutrient thing, making sure that you're eating enough protein, because without protein, you don't get leucine synthesis, you don't build muscle, and just like anything that's going to make you lose weight is going to be a risk of losing muscle. That's the nature of it. Them's the rules. You lose weight, you're going to probably lose some muscle if you don't control that. The other thing is, I feel like mostly 90% of our patients that are on a GLP-1 are also on creatine. Creatine, I used to just, creatine build a muscle. No idea it did all these other amazing things, with heart health and brain health. And I've been reading more studies on how creatine actually can affect methylation too and be another MTHFR potential kind of thing. That's a really cool thing. I had no idea. I was like, what's this creatine? Just randomly searching things like, what's this creatine methylation thing? And I don't know if we want to geek out on that in a little bit, but we'll keep it high level on this here. And so you hit a lot of the big ones. So, and then obviously make sure you're actually eating, because if you don't want to suppress the food noise so much that you just don't eat, and now you feel dizzy and woozy because you didn't eat. It's like, oh my God, I forgot to eat today. That's not good. All these things here. But in the big picture of it, to me, the big three are strength training, resistance training, protein intake, and creatine are usually the big ones. And hormones, I call the big four.
And sleep. I mean, it's all important, right? It's all important. So what is your strategy, like maintenance versus long-term, when you use these medications in women? Like, do you plan on using them forever? Just really low doses? Do you plan on tapering them? Do you cycle them? What helps you determine when somebody can actually stop them? What does that look like?
A lot of that is subjective and the in-body, right? But first, I always say this thing, at some point, your body's going to stop losing weight. You will not inject yourself into a skeleton. That's just like what happened to Dr. Smith. She just a head and bones. She just keeps injecting. She didn't stop. She just pushed it to the limit. I don't know what we're doing here. She's a bag of bones.
There is a point of diminishing return, is what he's saying.
Your body is going to say, enough, bro. Like, this is it for you. I am not losing. I don't care. You're going to get to that point, right? But sometimes that point is, for most people, that's too much. And so at some point, most people are going to say, I hit my goal weight. I like my body. I just had a patient this morning. She's like, man, I feel so lean. I feel great. I don't want to lose more muscle, lose more weight. I'm really good here. And so that's when we start, what's our off-ramp? What's our exit strategy? Right. And so it varies person by person. One of the potential off ramps is like, okay, let's reduce your dosing to every 2 weeks or every 3 weeks, right? Depending on the person, right? You can say, hey, let's try this every 2 weeks, see how they feel. A lot of people, especially if they've hit their goal and they've they took the time, and this is big, and they took the time where they were on this medication, on this therapy, to change their habits. I'm eating cleaner, I'm eating better, I don't drink as much, I'm working out more. Your habits have shifted. If you're going to stop this or slow this down, you need to maintain those habits. Those stay. When the shot goes away, those need to stay. Damn, I like that. Let me write that shit down. The shot goes away.
The habits need to stay. I like it.
Oh, man, that's official.
Our Instagram hook for this podcast.
Man, look, that is on a t-shirt, man. Watch out. And so that's a big one, right? Because you want to make sure that people are maintaining the habits and the changes, right? So you hit some big ones. And then sometimes there's also the option of titrating the dose down. It's like, hey, I like weekly. It's easier for me. I don't want to forget, okay, you're here. And there are some patients we have on tirzepatide and some other where they're slowly, every couple months, they're just titrating back, right? Until they get to that micro dose or maintenance dose that we feel comfortable at. Me personally, when I look at the long-term benefits, when it comes to neuroinflammation, when it comes to systemic inflammation, some of the kidney benefits, all these other benefits when you look at, that's great. It's an old article now, but it was like the non-weight loss benefits of GLP-1. It has this beautiful chart. It's got a GLP-1 in the circle, and it's got all these different systems, brain, kidney, liver. Like, I'm all about that. I ain't trying to lose any weight, but if I can get some of those benefits, I'm very okay with doing a dose that does not affect my appetite to get some of those systemic longevity benefits too. So I think it's person by person and a strategy. But again, I don't foresee for many people, some people, I'll say it a different way. It's like, do I see this as something people need to be on a high dose for the rest of their life? I hope not. But I do hope that it's something that, especially as we get more research out there on the benefits and long term, because again, it's still kind of new. Let me be clear. These, especially the tirzepatide and the retatrutide, it's still kind of new. And so we don't have like 30, 40 years of data on it as well. So we have to look at that.
Right. So with semaglutide, we do in the form of Byetta, right? Like it was around in the 90s, and then Victoza, but it's true. These are newer drugs. But what I'm hearing you say is it's very person dependent. It's dependent on what we're trying to do, what symptoms you're having. And so again, this is why it's really important to work with a provider who's looking at your labs, who can help determine like, hey, you need to stay on a tiny dose of this GLP-1 for another year because your insulin's still mildly high and you have high triglycerides and you have high lipoprotein A and you're more at risk of, having cardiovascular issues. And we know that this helps, so it's a shared decision-making tool. There's not like one exit ramp, right? Everyone has a different exit ramp. And so this is why it's so important to work with somebody who can help you figure that out. Because if you're out there trying to figure it out on your own, because somebody sent you a script and told you to go up every 2 weeks, you might not make the best decision for yourself. And so I think that's really important for people to understand as well. I want to ask you too about some of the hype I hear about the microbiome and side effects. So number one is do GLP-1s, does retatrutide, tirzepatide change the gut microbiome? Do you know anything about that? In a clinically meaningful way. So obviously there are some changes that happen, but is it meaningful? Does it really matter? And then I know there's still a lot of studies going on about that, but also what about the side effects with nausea, reflux, constipation, fatigue, things like that with retatrutide? Are they as bad as what everyone says on social media?
So I'll start with the side effect piece of it because that's an easier one, more data on that. A lot of times the side effects when it comes to these medications, a lot of it has to do with the kind of many lifestyle changes need to be made. So if someone is still eating more fattier foods, still eating kind of foods that are not good for you, we tend to see a little bit more with that, especially if you're still drinking alcohol with that, you tend to see a little bit more. I will say the first kind of gen in this new iteration of GLP-1s with the semaglutide, those tend to, from my clinical experience, I've seen more side effects with those. And then sometimes some people I'm feeling, but I'm getting reflux, getting things like that. We get their dietary things. They cut back a lot, still something going on that I may say, okay, let's try tirzepatide. I've seen a lot of those GI side effects either get minimized or go away completely doing that as well. So I think that's a big part of it. But then we also have this kind of handout we give the patients. It's like a GLP-1 success where it says, here's some of the things to do to deal with that. And we'll talk about eating a little slower. Don't overeat, cutting back on alcohol, reflux things, like, if you're getting it, there's things you can do, like supplement. We have like a little supplement guide. Here are some things to do that can help as your body gets used to the medication. Here are some things that you can do. There's some homeopathic things on there that can help with nausea. And then we say, hey, especially if you switch from semaglutide to tirzepatide, you're still getting nausea, we talk about maybe there's an opportunity to have a conversation about Zofran possibly being an option as well. But at the end of the day, we want to make sure that they are doing the right things. And a big one with the GI, water is a fascinating one because some people, when they don't drink enough water, which can happen, especially if you're eating less food, a lot of people associate their water drinking with their meals. And so if you're eating smaller meals, eating a little less frequently, you may drink less water. Now you're affecting the colon, the large intestine, lower intestines, and now there may be more of a constipated state. But then there's a possibility that some people, when they drink less water, there is, I may goon the science up, so I'm not even going to try it. There is a possibility of that may leading to more diarrhea too, with too less of a water intake with some people. So obviously water is a big one, making sure you're mitigating that as well. Now, when it comes to the microbiome, I just started getting into some of those studies too, so I don't know the full scope of that. But there are some newer studies showing that it can affect the microbiome in both mostly positive ways, also some negative ways too, especially if someone is eating they change their diet, if it's not so much a diverse diet as well. So those I'm going to look into some more, but those are relatively new, like you said. But
Yeah, and there are some studies showing that maybe it's more harmful for acromantia. But again, it looks at if you're not eating a variety of food, right? Then it can lower some of these good beneficial bacteria. And so, but that again goes back to you as the person eating, making sure that we're eating the good things, right? The fiber, as opposed to just some people will tell you when I take these medications, I crave a lot of carbs. And so I'll eat the carbs and then I'll be full. And then we're not eating as much of the, plants and fruits and vegetables. So that again goes back to just making sure that people realize how they're supposed to eat, which is our fiber first and then our protein and then our carbohydrates. But in general, I think my point of asking you that question was a lot of these side effects that you hear about that are terrible were in drug studies where doses were really high, right? Not in studies where we give people microdosing, which is sometimes just replacing what your body would naturally have, right? Because I think that's another thing people forget about this is some of these peptides that we use and like GLP-1 is something your body naturally makes. And so we don't make as much of it as we get older. We don't make as much of it as we have, trained our body to not because we overeat and do some bad things, right? And so if you're giving somebody a small amount, it's almost like you're just giving your body back what it had before. And we weren't born nauseous. We didn't walk around at 3 and 5 and 7 and 10 years old nauseous. So if you're not giving people huge doses and they're not eating like idiots, then usually that doesn't happen, right?
Yeah, and when you look at the kind of dosing schedule, and I was thinking about something you mentioned earlier. We had our first podcast, and we were talking about microdosing a little bit, and I'm like, I was very new to the whole microdosing concept, and so my microdosing was like, oh, you mean like psilocybin? You mean like ketamine? Like, oh yeah, just take a little small dose. Yeah, you're all good. No, I get it. Oh, a little bit every day. Yeah, it was like weird. It was a weird answer, so hopefully you deleted that from the first podcast. But now I realize that the issue is like if you follow the dosing schedule that the manufacturers put out there, that's aggressive. Going from 2.5 to 5 to 7.5 to 12 that's too much for most people, right? And especially when it comes to like semaglutide. You follow that schedule to 2.5, 5, 7, 12, 15, something like that. Like most people will get side effects GI-wise going that fast. That is really fast. And most people I always say, man, we go slow and low. I don't want to be over aggressive because you think about some of those side effects, when you think about the skin sagging, you think about the muscle loss, you think about the Ozempic face. Full disclosure, I just found out about Ozempic badge like 2 weeks ago. I had to text somebody. I was like, is this real? I saw this article and I was like, oh my God, like, is this really happening? Because I was like, I gotta add that to the questions. Look, may have the MAs ask that question in the beginning to start. But, it's just like, hey, just to make sure it's like, look, be mindful of that too, because anything that's going to reduce skin laxity is not just facial skin. You got skin all over the body, and apparently there's a market for vaginal restoration with the results of that. So are you doing that? Is that a thing you're doing?
I'm not doing vaginal restoration, but I have heard of it. And I mean, it's true, right? If you lose muscle or you have skin laxity anywhere in your body, it's going to show up. And unfortunately for women, as we get older, gravity is not our friend. So everywhere.
Look, man, you just got to be mindful of that.
Yeah.
It's a discussion to be had because it's not like especially if we're not asking the question, it's not
Mhm.
because you suddenly aged 10, 15 years and it's 6 months you've been on it. This is a side effect to be mindful of, right? Another
Right.
reason why we want to make sure you're losing the weight slowly, gradually.
Mhm.
And I remember, man, when I first started in my GLP-1 prescribing life, I had a few patients like, I'm not losing weight fast enough. My friend lost 30 pounds in the first month. And I'm like, well, you might want to go see your friend's doctor because I don't want you losing 30 pounds in a month.
Yeah.
I just don't. I'm not gonna have you out here with your skin sagging, especially if you're already overweight. I'm not gonna have you out here looking like a damn stingray because you've lost so much weight. And no, I'm not doing
Well,
that.
and it just
Yeah,
metabolically, you're going to have a lot of other issues later, right?
yeah,
So
no,
that is,
no.
again, you need to get it put on you need a t-shirt, go slow and low. Is that what you said? Go slow and low,
Slow
or
and low.
start low and go slow?
Start slow and low. I'm gonna go slow and
Start
low.
slow and low. Okay. So, and I agree. Like, I don't want you losing. I tell people 1 pound a week of fat, 1 to 1.5 pounds a week of fat is ideal. You didn't
Yeah.
gain 30 pounds in a month, and you shouldn't lose 30 pounds in a month. But as Americans, I said we wanted to lose 30 pounds before we came to see you, Dr. Jones. Like, we wanted to lose it yesterday. So we're here today. So
I know
let's go.
exactly. Make it happen, bro. And the other thing is to kind of think about is, our bodies are very smart metabolically. And it's almost like just imagine, think about your thermostat. It's like if my thermostat is set at 80 and I take it to 60, and then like, oh, let's go back to 70, because the dose is too much, and you're just swinging wildly. The metabolism has to catch up to that. It's a difference between kind of slowly, and another way to describe it. Let's just say you have the temperature set at 80, I drop to 60. You're gonna really feel that temperature drop. It's probably gonna feel
Mhm.
freezing. But if I'm like, hey, weather's changing, let's go from 80 to 75, 72, a gradual decrease, your body can keep up with that temperature change a little bit better. It may not feel as drastic.
Mhm.
It's very similar to your food intake and what these medications are doing. If I dose it too fast, I'm changing your metabolism so quick. When you go back and say, I'm going to start eating more, or when I decide to stop the medication, the weight may come roaring back because you swung it too far, too aggressively. So that's something to be mindful of too.
Yeah.
Yeah.
So I want to kind of transition and pick your brain about some other things that you're good at,
Yeah.
and we'll make it quick. But I want to talk to you about metabolic body composition peptides. So most notably like CJC with ipamorelin or tesmorelin or samorelin. For women asking about this, and I think this is a great peptide for body composition, assuming you're doing what you said, the sleep, we're lifting weights, our IGF-1 is not 600. What is realistic and like goals that people can expect from doing peptides like this in the perimenopause and menopausal stage? What are contraindications and what needs to be monitored?
Yeah. So the growth hormone releasing peptides, and there are quite a few. You have samorelin is OG. Then you have CJC ipamorelin, CJC 1295 ipamorelin, and you have tesmorelin, which my analogy that I like to use is you go to the gas pump, there's 87, 89, and then there's 91, 93. And I think of samorelin as your kind of 87. It's kind of like, yeah, the car will go, may not go as fast. May not be good, might not be good for everyone's engine. And then, okay, in the middle ground, okay, like, hey man, I really can't, I was like that, god damn, 93 is like $8 a gallon. I'm just gonna do this. Let me, we go down a little bit here. And then obviously tesmorelin, put in perspective, samorelin is that lower grade. CJC right in the middle, tesmorelin, which is kind of the higher grade, third generation. There's some different reasons why. Now, samorelin is the first one approved. It does work, but obviously the dosing has to be a little bit higher for it to be effective. It does stimulate hunger, shorter half-life. I'm not a fan. I have been doing peptides for, coming up on 7 years or so. I have never written a samorelin script. Just haven't. CJC 1295 and ipamorelin, I do like that one in many ways here. A little bit longer half-life. I do like
Mhm.
how the effects it has for body composition and muscle building. And also, it's one that you have some more, because of the half-life of it, you can do a little bit of manipulation with the dosing that you can't do with the other two. Like if I have you dose CJC ipamorelin twice a day, bedtime and in the morning, I tend to see some very impressive body composition changes. if someone's really trying to build muscle, like, hey, I need some muscle fast. I got this wedding. I got this beach thing I'm going to. I may say, all right, man, let's go for it. Let's do 3 times a day. I tried 4 times a day. It was just with the food intake thing, it was way too hard. And I wouldn't do that for a long period of time. We're talking like a month or two, but that tends to be more anabolic. Now, testosterone, on the other hand, was originally created as Egrifta, which was a medication to treat HIV lipodystrophy. And it has some great benefits on lowering cholesterol and lowering visceral fat. So someone, especially with the in body, and I see your visceral fat is above 10, okay, we need to fix your hormones, you need to work out, change some dietary things, but we can use testosterone as another lever to help lower that visceral fat. So really great for that. Now, to close this out, some people will tell you that they felt better on CJC 1295 ipamorelin. Like, I felt like my sleep was better. I felt like my recovery is better. Then I have some people like, man, testosterone is the best thing I've ever had. And that's why there's some subjectiveness to it. But in general, we usually will start people. I like CJC 1295 is a good place to start for most people, especially if they don't have the visceral fat. They do a cycle of that, like, hey, let's try testosterone, and then they have a comparison in how they feel between the two. Am I doing the 6-7 thing the kids are doing? Anyway, so there, so in that case, there's an opportunity to figure out what's going on subjectively, and you're able to make that decision.
Do women ever tell you sometimes that the testosterone or the CJC makes them feel puffy?
Yes, in the beginning. And I always warn of that when they start. I'm like, hey, things to look out for: headaches, joint pain, stiffness, and you may get a little bit of water retention, especially in the beginning. The water retention for a lot of people is just like you've seen bodybuilders. They got the growth hormone belly, because growth hormone does lead to a little bit of water retention, especially in the beginning as your body's surging growth hormone. That tends to pass a little, and again, be mindful, especially if you got like, hey, I'm like, look, if you got like, I got a beach thing, I've never been on this peptide before. I might say, you may not want to do this right before that. Give it a little bit of time, especially, if you can't have a wedding in 2 weeks, so let's start this right now. I probably would say, hey, let's start it a little sooner, maybe do something different. I have seen that, but it also passes. It just seems to be a little bit in the initial as well. And the last thing you asked was what to look out for. And one of the things that and this goes down to what you said earlier, make sure you're working with a practitioner who's trained, because some people can literally develop antibodies to GHRH peptides like testosterone, CJC 1295, and sermorelin. And if ignored, that can lead to full-blown anaphylaxis. It can happen. It has happened. So if someone's starting these peptides and they're getting a little bit more than a typical sharp, pointy object in the belly sensation, as in, I'm getting a rash, this is itching really bad, I'm getting whelps, this feels allergic, you need to let your practitioner know right away, because these may not be the peptides for you. And it has happened. I've seen it happen. Patients come from other clinics and you're like, wait a minute, okay, this is not for you. So that's a big one to be mindful of. Huge one to be mindful of.
Yeah, I like that. Another question I get from people is, some people say it's fine to take these stacks of peptides like Clo and Glow and yada yada. And then a lot of people say we shouldn't stack peptides and put them in the same syringes, which I don't think you should ever put two. If you're going to get 2 separate peptides from different vials, you should never put them in the same syringe, in my opinion. But I also have a lot of people say, well, Dr. Smith, you say not to stack them. And I just don't love it when they come stacked, because I don't feel like you can appropriately get what you want from every peptide, right? Like a lot of these, like the Glow peptide, it's great. You get 3 peptides in one, it's cheaper, but it's because you're getting lower amounts of those peptides, right? And I don't know that we know enough about how those peptides play together in a vial, stored for a long period of time. So I just feel like if you're going to spend the money, you should get them separated, and then we should give you the dose that we want and can tailor to you for each peptide. But I have a lot of people who say, well, what about the CJC ipamorelin? Isn't that 2 peptides in one? Like, so you don't want us to stack them. So explain that to people.
Yeah. So let's start with, I like that. I never had a patient come back at me like that. You got some bold patients.
I have very informed. Like they're just
I like that. No,
like, hey, these are 2 together and you don't like peptides together. So like, what's with that?
Well,
And I'm like,
I better be ready for that question, because it's coming my way soon. Well, first off, there are a few peptides that have been studied for stability, efficacy, all those great things in combinations. There's not many of them. CJC 1295 and ipamorelin have been studied for that, so they are stable. They're not making a new peptide together. Those studies are done. Another one, BPC 157 and thymosin beta 4, those stability studies were done. And the other thing, we'll get into some of the combination, it's because the pH of those peptides match, neutral pH. It's not some swing between this is more of an acidic, this is less acidic, has different ions in it that can change. Copper, for instance, GHK copper, that ion can start doing all kind of cool stuff because copper does redox. I don't want to get too geeky on it, but I'm mindful of that. So I want to say another, oh man, what's the other one I was looking at? So I think there were some tesmorelin, ipamorelin studies have been done as well. There are a few. CJC, 1295, and IGF-1, there were stability studies done on that. So there are some combinations that were tested when peptides were first being developed and all that stuff, which is great. The issue, now this is where it gets a little tricky. Because from a scientific standpoint, if certain peptides should not be mixed together for a couple of reasons. One, because if the pHs are different. Everyone's taken at some point in their life has taken a chemistry class and has like, hey, put this acidic thing here with this alkaline thing and then add this some baking soda to it. And then you start seeing the foam coming out of the thing. And obviously that's not happening in the vial or the syringe, but things with different pHs can affect the chemical structure and how they work. That's important, right? And so I'm mindful of that too. And the reason I say it's tricky because you will have people saying, hey, I did this stack. I felt great. But I was like, you also got it from an online kind of research company. That's whatever. And there are some cautious of that, and I just think that there's a better way to do it. Yes, it's convenient. Yes, it's a little cost savings. But again, you can adjust the dosing of it. And the fact of the matter is like, I don't know if you're I don't know because no one's really done those studies yet because obviously pharmaceutical companies ain't putting the money into it to run the actual long-term studies. So we got to kind of go off of where we are. And where we are is that, like you, if I'm going to do a stack of peptides, I'm probably going to recommend doing them separate. I understand people are seeing it, getting the benefits from it. But I also say, like, look, if you decide to do a research peptide that's got 5 things in it, that's between you and God. Don't call me when you start growing a giant knot in your forehead. I'm busy, I'm tired. So it's kind of one of those things, it's like, if you decide to do it, it's just like, that's your decision. I am going to counsel you a little bit different. I'm going to recommend differently. And here are my reasons why. That's just my take on it. But again, I'm like you. I don't want to mix certain peptides in the same vial or syringe. It's okay. Those needles are small. I think about this invention, man. I haven't got to it yet. I was thinking about trying to create something where you can have you can draw and it's like a little clip thing. You inject it. You can do 3 peptides at one time. But I'm like, maybe not do that because they are kind of right there at the injection point. That's probably like mixing. But anyway, that being said, I'm like you. I want to do them separate.
Just take different shots.
Take different shots, different parts of the body.
So what I'm hearing you say then for the patients who ask that is CJC and ipamorelin have been studied together. The pH is good and we know that they're stable. Otherwise, we shouldn't be randomly. Also, TB500 and BPC, which I was going to talk to you about a couple of those, but I think we're going to run out of time. Those can be stable as well. I know. And then the other 3 things that I definitely have gotten from you that I'm going to use is when the shots go away, the habits need to stay. Go slow and low. And I like that. If you are one of my patients and you tell me, hey, I'm going to get my peptides from somewhere else online, et cetera, whatever, it's cheaper. Instead of trying to, counsel them on all the bad things that can happen, I'm just going to say, okay, that's between you and God. And you can call that provider when you have problems because they always end up calling me or like, hey, this isn't working or this isn't. And then it becomes my problem somehow. And I'm like,
I know. And again, I'm not just going to say that automatically. I'm going to give you the reasons why. If you choose to do it, I mean, that's you and Jesus, man. Like I did my part. Right. And I like that. That's how I go.
I like it. I like that. So I'm going to ask you some really quick questions because this is my lightning questions. I want your answers too. What is the most common reason women plateau on GLP-1s?
Being at the same dose. Everyone's going to plateau, but possibly staying at the same dose too long is the big one. That'd be my number 1 reason right there. So like I said, you can still increase a little bit, but going slow and low, like you've been at the same dose for 6 or 7 months, 8 months, you're probably going to plateau.
Okay. What is the biggest perimenopausal weight loss myth that you think is floating around?
Oh, that's such a good one. You know what? I think one of the big ones is that, you're not in menopause yet. You don't need testosterone.
Or progesterone. Because you don't live with that woman. If you live with that woman, you would give that woman progesterone.
It's like, what's that in my mashed potatoes? They're so bitter. I don't know if that's some new salt I'm trying.
Yeah. No, I agree. I also think one of the biggest perimenopausal weight loss myths is that you should just exercise more and eat less, right? Like or, what is it? HIIT exercise, like just trying to ramp your cortisol up even more. It doesn't work.
Yeah,
And
no.
then what's the best single habit to preserve muscle in midlife?
Neck and neck strength training. Do not be afraid to lift weights. You can find time. Don't be afraid of that. Yeah, you might not be as strong as you used to be, but you still need to put some resistance on that muscle. A, because it's good for you structure, but also when you do resistance training, you release these proteins or these molecules called cytokines. They're called myokines, and myokines can be anti-inflammatory, help with brain health, BDNF. They are amazing. So, but you got to put that muscle under tension to get the cytokines. And then part two, you need creatine. You need it, you need it, you need it. Your body produces creatine, but guess what? The brain keeps all of it. It ain't giving you none of that creatine. I'm keeping all of that. And whatever else you make, your muscles are like, I'll take a little bit of that, it ain't enough. And so you need to supplement a little bit more creatine to replenish those muscle ATP stores.
I could not agree more. And then the last three questions I ask everyone, I don't know if you remembered them from last time. I'm going to see if your answers were the same. What is one food that's most beneficial and why? First thing that comes to your head.
The number one food. Oh man, I gotta go. Can I put protein as a food? Oh yeah, I'll say
No, it has to
protein
be
is
a food.
just one. It is a food group. Goodness. Okay.
Pick one protein.
Okay. Chicken breast.
Chicken.
I
And
like
it's because it's protein, right? And so it's
Yep,
good
yep.
for your muscle. Okay.
Great leucine content as well. And
Chicken.
yeah, red meat's great. Don't get me wrong, but I guess some people, depending on their cardiovascular status, and they might not get in the leaner cuts. You can't just be eating a ribeye every day and be like, oh, I'm good. So lean
Okay.
protein, lean meat.
What is one thing that anyone listening to this podcast right now can do that's 100% free that will help their health?
Sleep, better sleep. I know it's hard to say that because sleep is multifactorial, but at the end of the day, if you can make I'm going to say this as a part two. Yes, you need more sleep, but if your person is a horrible sleeper, do not fixate on it, because if you go to bed worried about like, oh, I don't know if I'm gonna get no sleep, you're stressed out about it. That's a cortisol spike. You're basically perpetuating poor sleep. So don't think about it. Just go to bed. Let your body do what it do.
Yep, I would not agree more. Sleep. And again, this I try to give people just bite-sized things they can take out of this and then go implement, because we don't want, like, no one's perfect. I'm not perfect. You're not perfect. So, but I think the more people hear this, I mean, you're probably the 40th person that said sleep, then people are like, oh, I should really prioritize that, right? Yeah. And then the last question is, what is one thing you wish that you would have known about your health 20 years ago that you would have done completely differently?
I would have found me some peptides. And I say that because I'd be like, Google, if I could write an email to myself 20 years ago, you need to find about these peptides. They're not here in the States. Get that shit from Russia. Do what you got to do, bro.
What peptides would you have been getting from Russia 20 years ago?
Man, if they weren't here, BPC 157. Let me tell you something. I stubbed my toe 2 days ago. Let me tell you real quick. I know I ain't got all the time. I was walking in the dark, walking too fast, stubbed my toe. I heard a crack. I screamed. I was like, holy shit, something ain't right. I looked down. This damn toe was going its own direction. It was trying to leave the building. And I was like, no, you don't. Pop it back in, right?
Oh.
I was so much pain. And I'm like, ah. And so I was like, okay, what do I have? I started doing a really, really high dose of BPC 157, and my limping is down like 70%. Man, if I had that back in the day. Now, I know that's kind of aggressive, but if I could tell myself one thing realistic, stop drinking so much alcohol.
Yeah, I would agree. Alcohol, sleep, being nicer to ourselves with sleep. I mean, when you go through med school, you're not very nice to yourself. You don't sleep very well. You don't eat very well.
Man, I'm be real with you. I'm a sleep hypocrite. Because I know all the benefits of sleep, and there are nights where I'm like, nah, I'm gonna stay up and keep watching this TV show. And there are some nights I'm like, oh, I'm such a sleep hypocrite. I know better. Why am I not doing this? It's not perfect every night, but I don't beat myself up. And I'm like, well, tomorrow's a new night. Let's get back at it. But there are going to be nights where you don't sleep perfect. Be mindful and don't beat yourself up. You have a bad night of sleep. We're all going to have one.
Yep. Well, I appreciate you coming back and talking to my listeners about peptides. I know there's a lot of confusing things out there. I love it when people, are doing what they're supposed to do and actually helping people. And although you say that you wish you didn't treat perimenopause, we're all glad that you do, because I think it's one of the hardest things to treat. It really is. Like, some days I'm like, why am I doing this? This is wild. It is wild. I joke with my husband that, like, I feel like I can go anywhere and, like, you can throw anything at me and it's not going to disrupt me because I do it all day long, right? If you see 10 to 12 perimenopausal or menopausal women a day, you never know what's going to happen.
Every single one. It's like, is that right?
But the really cool thing is, I was reflecting on it I was reflecting on it via text message the other day with someone, and I said, it's just a blessing that people trust you enough to tell you some of the things that they do, and then that they are so vulnerable in front of you, and like they're sick, they don't feel well, but it's just so cool when you help them feel better and then they come back and they're like a totally different person. It's just a really like not very many people get to experience this as a human being, right? Like the work that we do, although sometimes is very hard and tedious and long, and it's just really rewarding because I've been there myself too. And it also helps you give people grace. Like I used to just be very frustrated with people in general, and I give people a lot more grace now because I know sometimes they're going through things that you don't realize they're going through, and it is really like biological, emotional, chemical. Like there's really nothing that they can do until they get some of that balanced. And I think it's cool that you as a man understand this. I think my husband's starting to understand it, but I wish more men understood it to the degree that like we have to live it,
You have to be like, all right, man, all right, let's see you in a couple months. Let's try it again. Let's do this one more time. Let's see what we get, and you make the changes. And sometimes you got to take a stick of dynamite and blow the whole plan up. Like, we got to start. This ain't working. Let's blow it up. And, and hopefully you building up trust with patients and like, look, I need to blow this up because for you, your body ain't feeling this and we need to give you what you need. So sometimes it's okay to do that.
Yeah. But it really really does require individualized care. And that's what's missing in this country. And that's what's missing in health education is just like, in school they taught us everyone fits in a box, you give them a medication, you move on. And I will tell you, as a perimenopausal woman now who takes care of perimenopausal and menopausal women, there ain't no boxes that most people fit in. Like there's some jaggedy edged, like sort of semicircular, like I very rarely have someone I'm like, oh, put that peg in that box, like it doesn't work like that in real life. It does if you're a bad doctor. It does if you want somebody to just get out of your office and you want to fix 20% of their symptoms and you don't want them to ever come back. But if you really want to optimize somebody, they're like, everyone is so different, right? And so it's just, but that's cool because it's almost like I'm a detective all day long, right? Like I don't know if you feel like that, but I'm like, what sort of clues do we have to figure going on?
That one clue, you're like, oh man, my kids are stressing me out. Everything was the same, but they're back from school, and you're like, oh, it's always that one thing. But no, I really appreciate your process and thought process on it, and and we talked when I had you on my podcast. The fact that you made the leap from endocrinology to what you're doing now is great, and you can seriously help people at a level that you couldn't before, and so I commend you for doing that too.
Well, thanks. Tell everyone, if they didn't listen to the first podcast, where can they find you? I know you're very active on social. We'll link all of that. Do you tell everyone about your podcast, where they can find you if you have anything big coming up that we need to know about?
Yes. Yeah, so I look like I'm very online, but I'm not. Like I use apps to post for me in advance, and I try to not be on there. And I'm like, oh gosh, I'm not on as much as I want to be. But anyway, so social media under Instagram is under at Dr. Jones, all spelled out, _ Dr. Jones. So Dr. Jones, like Indiana Jones kind of thing. There I have a podcast, the Dr. Greg Jones Optimization Academy. You can find that on YouTube and Spotify and all of that. My clinic is Innovative Wellness Center with an E. We're here in Phoenix, Arizona. So anyone that's in the area that wants to check us out, it's me and 2 other doctors that are here with us as well. So we, enjoy what we do here. Those are the big 3. Those big 3. From those 3, you can find everything else. So.
We can find Dr. Jones. He's very entertaining. You guys should follow him on social media. And apparently I need to give him my social media manager to help him with his post. But thank you for joining me. And maybe we'll do this for round 3.
Let's do it.
Before you go, let's land this in a way that actually helps you apply what you heard today. If there's one big takeaway from my conversation with Dr. Greg Jones, it's this. In the world of hormones, weight loss meds, thyroid symptoms, gut dysfunction, and peptides, the safest and most effective path is almost never, what can I take? It's what's driving this for me and what's the right tool at the right time with the right monitoring. We covered a lot today. What's real versus hype, where GLP-1s and newer metabolic options may fit, how to think about peptides like CJC ipamorelin, tesmorelin, and the big safety conversations about stacking, sourcing, quality control, and working with a clinician who actually knows what they're doing. And I hope the biggest feeling you have right now is not overwhelm, but clarity and confidence. If this episode helped you in any way, if it answered a question you've been afraid to ask, or if it gave you language to advocate for yourself, please share it. Send it to a friend, a sister, a coworker, your group chat, especially if anyone you know is navigating perimenopause, menopause, stubborn weight gain, fatigue, brain fog, or just trying to make sense of the noise online. Sharing this is how information reaches the woman who needs it the most. And if you have 30 seconds, leaving a review is one of the most impactful things you can do. It tells the platforms the show is worth surfacing, and it helps more people find evidence-informed, practical conversations like this one. Finally, if you're listening and thinking, I want support with this, but I don't know where to start, consider becoming a patient with Modern Endocrine. Our team can help across 45 plus states, and we focus on the full picture: hormones, weight, thyroid, gut, and peptides, with an approach that's educational, individualized, and safety forward. If you're ready to stop guessing and start getting a real plan, we'd love to help you. Thanks for being here. Thanks for taking your health seriously, and I'll see you on the next episode.